Hey there everyone, and welcome back to Studying with Stephanie. Today we're going to continue our series on diagnostic imaging, and we are going to discuss diagnostic ultrasound. So let's get into it. So what is ultrasound? Ultrasound is a machine that uses crystals to create a vibration, therefore creating sound waves that penetrate the tissue and create a cross-sectional image. Ultrasound actually predates CT and MRI being used for soft tissue. But initially in the 1940s, 1950s, ultrasound was used to detect lumps in breast, and it didn't really become popular for musculoskeletal imaging until the 1980s. And it was actually created with the use of sonar navigation during the submarine era, and that was actually what predated and caused the ultrasound to come about. So like I said, ultrasound emits sound waves into the tissues, which then vibrates the tissue and sends a signal back to the transducer of the ultrasound machine. That transducer then moves that signal from analog to digital to create those images that we see cross-sectionally. The ultrasound machine consists of a pulsar, a transducer, a scan converter, and a monitor. Let's talk about each of these components. So let's start with the pulsar. The pulsar does what it sounds like. It pulses sound waves through the transducer, which is that ultrasound head, into the soft tissue. Again, the soft tissue then vibrates at different frequencies, and depending on the amount of energy absorbed or reflected back to that transducer, it picks up the image. So the pulsar is going to send the ultrasound waves during the pulse. And as that pulse is resting, it's going to pick up the ultrasound waves that are coming back from the soft tissue. So that's what the transducer is doing. That transducer is there to convert the waves, the sound waves, into the analog waves. And then we go into the scan converter. The scan converter is going to convert those analog images into digital images and clean up the picture a little bit more. And then lastly, we go into the monitor or the display, which is what we are viewing the ultrasound through. Now, the ultrasound is a real-time imaging system, so you can actually move the image to get a better idea of what you want. Now, when we're looking at the ultrasound, the transducer is either going to have those crystals lined up in a linear, which is more for musculoskeletal imaging, or a curvilinear fashion, which is going to be more for the abdomen imaging. So through the actual ultrasound, it is called the piezoelectric effect. And that is going to be what means when those crystals are shooken, they are shooken through electrical energy. That energy moves and displaces those crystals and then converts them into the sound waves. And again, those sound waves go into the tissue and bring back signals, and based on the density of the tissue, it's going to send back signals at different rates. So the conversion from the vibration and the electronic energy emitted from those crystals into sound waves, and then that return of waves back through different frequencies, different rates of speed, is going to be what the ultrasound uses, and that is called the piezoelectric effect. So an ultrasound is unique in the fact that it has a couple different properties that we don't see with other images. The ultrasound, as I said before, is real-time imaging. So we are seeing what's going on as it's happening in the body. With that being said, to create a better connection between the transducer of the ultrasound and the skin to get a better image, we need to apply a gel between the transducer head and the body. And then as well, we need to make sure that that transducer is in perpendicular alignment to the tissues that we want to see in order to get the best image. Now, because the sound waves are being emitted through our body can do a couple different things, which converts the energy from mechanical energy to thermal energy. Not enough to change our body temperature, but what happens is as those sound waves are getting emitted, our body is either going to absorb them, reflect them, refract them, or scatter those waves, which can make it a little bit difficult to differentiate between the tissues as we are looking through the image. Now, when we're looking at an ultrasound image, there's going to be essentially 3 different energies that we get back. And those energies are labeled as hyperechoic, so high energy reflection. So this is how the energy is reflected back to us. So when it is hyperechoic, it's reflecting a lot of energy back to us, and that image is going to appear bright. And then we have echoic. So a little bit of energy is reflected back to us, and those are going to appear a little bit darker or black in the image. And then we have anechoic, which means there's no signal emitted back to us. And again, these are going to be those dark images. So let's take a look at what comes out as dark and what comes out as bright. So on a normal ultrasound, we are going to find that soft tissue, tendon, fibrocartilage, and nerve are going to show up as hyperechoic, and this is going to be bright. Now, with these things, I have to note, it is sometimes going to be dependent on what that tissue structure is next to, because a nerve can appear bright next to the muscles, but dark next to the tendons that are a little bit more hyperechoic than the nerve. All right, when we're looking at the tendons themselves, we are going to see some parallel fibers, and that's what's going to be hyperechoic. But then it's going to also depend on whether we're taking that image in a longitudinal or a transverse plane. So in the transverse plane, the tendon is actually going to appear a little bit spotted, versus in the longitudinal, it's going to appear more of that striated parallel bands. And then again, like I said, we're going to see that sometimes a nerve, although it's hyperechoic, typically next to the muscle, when it's near a tendon, it may look a little bit darker. Let's go into what we see as hypoechoic in the ultrasound. In the ultrasound, we're going to see that bone, subcortical bone, is going to be hypoechoic, so it's going to appear more dark. Ligaments, when they're in relation to the muscle, are going to appear hypoechoic. Muscle is going to actually be hypoechoic, but like the tendon, it's going to have some striations of the parallel bands that are going to appear a little bit brighter. So the tendon is going to appear bright, but have parallel dark bands through it, and then the muscle is going to appear dark and have parallel light bands through it. So that's how we can determine the difference between the muscle and the tendon. Also, location, know your anatomy. If you are doing the ultrasound yourself, you are going to be able to palpate and feel what you should be going over. So the minute you put that ultrasound transducer on the skin, you should have a great idea of what you're looking at already based on your foundational anatomic knowledge, which is amazing. And then we go into the bursa, which is going to be between a muscle and a tendon, or a tendon and a bone. And this is going to appear as a hypoechoic line that's really thin. And then we have the nerve, which is again going to appear dark or hypoechoic next to the tendon, as I said. And then we have cysts, which are going to be anechoic, so it's not going to give us any signal back. So like I said, depending on the plane of where we have that transducer, the ultrasound image is going to appear different. When we have the transducer in that longitudinal plane, that longitudinal section, it's going to be essentially in line with the axis of the tendon. So if I'm looking at my biceps tendon and I put it longitudinal, that's going to be up and down on that tendon. So I'm going to actually get an image of everything kind of in this small space here. So if we look at the image here on the slide to the left, we're looking at an longitudinal sonogram. Sonogram is another name for ultrasound. Like I said, it initially came out when sonar was being creative. So it is a sonogram as well. So when we look here, we are looking at the anterior shoulder, and we're going to see, if you see the number 5 on the image, it is the one that is the most superior on the screen. That number 5 is the anterior deltoid. Like I said, muscle is going to appear hypoechoic with hyperechoic parallel lines. So you can see that the muscle overall is pretty dark, but there are parallel lines of striations, which are going to be those muscle fibrils. So that is going to be the anterior deltoid. If we look at the image below, where that transducer head is, what are we expecting to see? We know the deltoids are there. We know she's very close, she or he is very close to the bicipital groove and the biceps tendon. And in that area, we also have our rotator cuff. So when we go down a little bit deeper, number 2 is actually the subscapular tendon. And again, you can always palpate with the actual transducer if you're not too sure of what you're looking at. And then we go down into number 1, and number 1 is actually going to be that biceps tendon laying right next to number 3, which is the bicipital groove. And then we have number 4 is the transverse ligament of the humerus. Again, the ligament is going to be hyperechoic. Those tendons are going to be hyperechoic as well. And the muscles are going to be those hypoechoic with the striations. And then we take a look at the image on the right, and this is a transverse sonogram taken in the same exact place as the longitudinal. We're looking at the transverse sonogram, and transverse we know is across. Think of the transverse plane. So that transducer is going to line up right here. So you're going to get a wider image, but a little bit less space. So you're going to get more of a width versus a vertical and a depth here. So with the width of the transverse sonogram, we can only see a few things in this same location. You're going to see number 5. Again, that's the deltoids. We know based on where we're putting that transducer, we know the deltoids lie there. And because the deltoids are the most superficial, they're going to line up at the superior aspect of the image. And then we go right under, we're going to see that biceps tendon. And right under that, that bicipital groove where that biceps tendon lies in. And again, the subcortical bone is going to be hyperechoic. So it's going to have that bright line there so that you can see where that bone starts. And so you can see in the transverse sonogram, we get a little bit better image of the actual deltoid, biceps tendon, and the bicipital groove, and kind of how the consistency is in those tissues. We get a little bit more of that width of those tissues versus in the longitudinal, we get a little bit more depth of that image. So we're seeing a little bit further deeper into that image there. We are going to look at some images and some abnormal findings that we would see in an ultrasound. So when we're looking at the muscle, any disruption of that parallel alignment of the muscle is going to be a muscle strain. Those fibers are not going to appear as synchronous as they were, and there may be some dark filling, some hematoma formation there as well. And then when we see a complete rupture, there's actually going to be a retraction of that muscle. Again, palpation, appearance of the skin, and our normal physical therapy evaluation and exam is going to help us determine. The ultrasound is going to provide a little bit more information on the exact diagnosis though. And then if we look at the tendon pathology, we're going to see some thickening, we're going to see some decreased echogenicity, so a little bit of darker appearance of the tendon. The fibers as well can be disrupted. And then again, inflammation, hematoma, those are going to appear more dark. So if we have inflammation, we will see that more of a dark bogginess that can compress on some of those tendons. And then when we look at bursitis, we're going to see a widened area of darkness, and then we may see more of a thickening of that, of the wall, a little bit more brightness. And then we want to look at the ligament strain. Again, ligaments have nice linear fashion fibers. We're going to see a disruption in that and possible thickening of this ligament. And then nerve compressions, we're going to see that nerve more flattened out. And lastly, a cyst, which is we're going to see thicker synovium. We're going to see some hemorrhaging, and some time we'll see some debris in areas where we shouldn't. So let's look at the images on the right. We are going to start at the very top. Now, this image is an image of a shoulder. The image on the left is a normal supraspinatus. Here, it's fully intact. We can see the deltoid has that hypogenicity, hypoechoic, and it has some normal fiber distribution and linear fashion there of the deltoid. Right under it, there is a little bit of space of hypoechoicness, and then we see that supraspinatus tendon right over the arrows. So the arrows are pointing to the greater tubercle, and we can see that subcortical bone has a nice solid line there, it has a good congruency of that bone. And we know the supraspinatus attaches right on top. So we have a supraspinatus tendon, which is appearing more hyperechoic, a little bit brighter. If you see the asterisk right next to the supraspinatus tendon, that is the musculotendinous junction. So it is right where that darkness, that hypoechoic supraspinatus muscle turns into tendon, and there is that distribution right there. Image to the right is a torn supraspinatus with some humeral incongruency. So we see some thickening of that tendon there, that supraspinatus tendon. We also see a disruption. So instead of that nice white tendon, that brighter tendon, we can see some black circles, and this is disruption of those fibers. Again, the asterisk is pointing to the musculotendinous junction, which we can see is a little bit brighter, thicker. And then if you look down at the greater tubercle there, now we have some incongruencies in that humerus. So we can see that that tendon has affected the subcortical bone as well. The image right below in the middle here is going to be our knee. So we're going to look at the image on the left. This is going to be a normal knee. We are looking at the medial aspect of this knee. So the image is being taken at the medial aspect of the knee. So we see a nice linear ligament that the arrows are pointing to. This is the MCL. All right, so it's not thickened. It's looking really nice, thin, congruent, linear fashion here. Then we go right below it and we see the medial meniscus, which is the asterisk, and we see the femur. If you look to the image to the right, we have a meniscus extrusion. So the meniscal extrusion is actually, you can see that meniscus has now come closer to the surface of the MCL is now displaced. You can see in the inferior aspect above the tibia there that MCL is actually thickened compared to the normal. So this is a pretty serious meniscal injury as well as an MCL inflammation and sprain. You can see that there is darkness superior to the MCL there, and that is inflammation. Hypoechoic again. And then lastly, we are going to look at the very bottom image here, and we have on the left a normal median nerve. So the nerve, again, in the median is going to be near the tendons. So it's going to appear as dark. All right, so we have that median nerve, nice, circular, has a lot of good space there, versus the image on the right. You can see the arrows are pointing to the median nerve, which looks squished. And it's actually squished between the flexor tendons. As you can see on the bottom of the image where the asterisks are, that is a ganglion cyst. So that ganglion cyst is under those flexor tendons, and it is causing compression onto that median nerve, flattening out that surface. So ultrasound is really great at taking real-time images. It has high sensitivity and specificity, nearly compatible with an MRI, but it does have some limitations. Like I said earlier, attenuation can happen where that energy, those sound waves are being absorbed, scattered, refracted, and reflected through the tissues. But as well, we can have things called artifacts when it comes to an ultrasound. The first artifact, which is going to be any misrepresentation of the anatomical structures. The first artifact is called angiotrophy. And this is when a tendon or a ligament are going to appear dark, echoic, because the transducer is not perpendicular to the tissues that we're wanting to look at. And then we can have slice thickness artifacts, which is going to be the tissues having mixed properties of echogenicity and hypoechoic or hyperechoic. And this is going to be within each of the slices of what we're looking at. And then we can have acoustic enhancements, which is going to increase the echogenicity of structures that have limited attenuation. So if there's not going to be as much of that scattering refraction, it's going to appear more hyperechoic there. And then we have acoustic shadowing, which is going to be actually a decreased reflection from the structures because they are so deep. So they have a high attenuation on those tissues. So those tissues are absorbing a lot more of the energy. So they're going to appear a little bit darker. And then lastly, we have reverberation, which reverb is essentially a repeat of that vibration. So the tissue is reflecting between multiple different tissues in the transducer. So the reflection is going to throw off the image. So those are pretty significant. So we always want to, again, know the foundational anatomy, because another limitation with ultrasound is the actual ultrasound user. So as physical therapists, again, we need that foundational knowledge of anatomy, but it is important to palpate, to know what you're trying to view in the ultrasound image and know where to go anatomically so that you're getting a better image and you can know whether or not you're having those artifacts presenting themselves or if it is actually an injury or a limitation within those soft tissue. As well, ultrasound, unfortunately, is not very good at imaging obese patients, and that's just because of the depth that that transducer can penetrate through those soft tissues. And lastly, the ultrasound is unable to penetrate bone because of the depth, but also because of the absorption of those sound waves. We're not going to get that good image there, but we can see the subcortical bone itself. So that's ultrasound. I hope that this helped you. And I really think that it is an amazing, useful tool when it comes to physical therapy. It is a way to help diagnose and get a better idea of what's going on clinically. So if this is a certification or a specialty that you're looking into, definitely it can put you above and beyond and give you a lot of that clinical knowledge real time, firsthand, to see what's going on with your patients. If you like this video, please like it below, subscribe to catch more videos about everything related to physical therapy school and tutoring. If you have specific topics you want me to go over or questions, please drop it in the comments below. Again, I do one-on-one tutoring, so if you want to reach out, drop it in the comments below and I'll reach out to you.